one of the things I've done is written curricula for some specialized service lines. And you can take a look at this packet if you want to. This is what we get to our referral sources, nurses and doctors and stuff. So we have a service line on congestive heart failure called Fresh Air Program, service line on diabetes called the Sweetheart Program, our dementia service line, Memory Plus, our Freedom of Motion program, which has to do with arthritis care, Safe Homes program, which is fall prevention, and hospice support, which is today. So what you'll find in front of you are some materials. You'll see learning objectives for the class today. The second page is characterizes the work of Dr. Elizabeth Kubler-Ross, who we're going to talk about in a little bit. And then the last two pages, which come apart, is the test that we'll be taking at the end of this class. So you need to get 80% of the test to pass. So today we're talking about hospice support. One of the things I want to make clear is that we don't provide hospice care, we provide hospice support for families, dying people, and for the hospice agency. In home health care, there are kind of a continuum of different kinds of services. There's Medicare certified home health care and hospice agencies that are licensed by the Department of Health. And over here on this other side are private duty home care agencies, which is what we do, but we do more than anybody else. We do a lot of things like transfers that other people can't do, peri-care, Foley catheter care, colostomy care, those kinds of things. So, and the other companies can't really do that. So when you get a diagnosis of cancer or congestive heart failure, something that's going to result in your death, and you get a prescription for hospice, what you get is a great team. There's physicians and nurses and social workers and aides and clergy, and maybe they might even have music therapy or art therapy or a lot of different things. So it's a great team that comes to your side, but they can only be in the house a few hours a day. We can be there 24/7 if the family needs more help than that. And so that's what we do. And remember that when that hospice nurse comes in to the dying person's home, that they're our customer as well. Some of the feedback I get from some hospice agencies, not about my company, because I let you guys know all this, but about other companies, is that when there's an aide in the home, sometimes the adversarial relationship gets set up between the hospice provider and an aide in the family on one side. And so you have to remember that when that nurse comes in the home, that she's your customer as well, or he's your customer as well. And your job is to help them help this family. All right? So remember that it's not an adversarial relationship that we have with these guys. They're doing a great job, a wonderful job. So a little bit, and you guys can pipe in if you have experience. First of all, let me just hear, on a professional level, who's had experience with death? You have, Mary. Nobody else has had to deal with a dying patient? Okay. It can be very challenging. I've been an emergency doctor for 20 years, so I've been around a lot of death. And initially it's really difficult, really hard. So if you are staffing any of our hospice clients, remember what a privilege this is, to be present with somebody while they're dying and as they die. And if you need to talk about that after it's over, you all have my phone number, just give me a call and we can talk about that process, what's troubling you. Because the process people go through when they're dying, their families go through that too. And guess what? You do too, because you're going to be like part of the family after a while. And I know all of you do that kind of level of work. So hospice actually started back in the Middle Ages, kind of like during the Crusades. And there'd be taverns and wayhouses that Crusaders would stop at. And they would take in people that were sick and people that were dying. They would take care of them until they died. More recently, it's become a modern movement back in the 1960s. And there's one particularly influential figure. Her name is Elizabeth Kubler-Ross. She was a Swiss psychiatrist. And she studied death and dying. She studied the dying person and stayed with them. Even when I started medical school, a lot of times physicians would be frustrated if someone was dying because they don't want to, especially if they're accepting they're dying, because our job is to save people's lives. And so once they were dying, then a physician wouldn't be paying attention to them anymore. And so what Elizabeth Kubler-Ross found out is that they really do have very specialized needs. And if you turn to that second page, you can see there's these 5 well-described stages of grief. And you go through these with important events in your life that result in grieving. Death is one of those. Death of a spouse, loss of a job, things like that. So the 5 stages are denial, anger, bargaining, depression, and acceptance. And there's a little bit of a description of each one of these stages here for you. And everybody's journey as they're dying, and we're all going to die, is unique and different and specific to you. So when you die, you're going to go through a different process than when you die, which is going to be different than when I die. And so these stages aren't necessarily one right after the other. So Amanda, I give you a diagnosis. You come to the ER, you've been coughing. Actually, you're a better example. You come to the ER, you've been coughing, and I do a chest x-ray, and I see you have lung cancer. Okay? And then I say, I'm sorry, but this is advanced and it's going to kill you. All right? So people might approach that with, you're wrong, you're an idiot, and I can't possibly have lung cancer. Or they might get angry about it. Damn it, why me? I never smoke. Why do I have lung cancer? Or they might start bargaining, like, okay, I've got lung cancer, it's going to kill me. Just let me see my daughter graduate from high school. That's all I want. Just let me last that long. Or you get depressed about it. It's kind of obvious what that means. Or acceptance. Now, you don't go necessarily from one stage to the next stage to the next stage. You might start at anger, go to acceptance, go back to denial, skip bargaining altogether, get all the way to acceptance again, and then back to denial. That's okay, right? There's nothing wrong with that. That's your process. It's not our job to help people, okay, now that you're done with denial, now it's time for anger. You're mad about this, right? It's not our job to do that. Our job is to help them process at their own rate. And they may never get past denial. They may die in denial. Nothing wrong with that. That's fine. Now, Elizabeth, if you come to get your cough and you have lung cancer, and I say, well, this is really advanced, I'm going to prescribe hospice for you, I have to believe that you have 6 months or less to live. And I'll write a prescription for hospice, and a hospice provider will come to you. And you don't have to have cancer to get hospice. You can get hospice from dementia, a hospice prescription. You can get hospice from congestive heart failure. It doesn't matter what the diagnosis is. I just have to believe you have 6 months or less to live, and then you'd be covered for hospice. And if you take advantage of it, if you say, yeah, okay, that sounds like a good idea for me, you have to agree to forego curative care. You're no longer getting your chemotherapy to save your life. You realize you're going to die. It's no longer about length of life. It's about quality of existence, right? And that means dealing with your pain and your fears and your suffering. It might be physical pain. It might be anxiety about, well, shoot, I'm not leaving any life insurance for my wife, my family. How are they going to take care of themselves? Palliative care is addressing or spiritual, maybe it's a spiritual issue. Palliative care is addressing all of those things, but not curative care. Now, Liv, if you are on hospice and you say, okay, fine, I'll sign up for hospice, can you change your mind?
Probably.
Yes, you can change your mind. You can change your mind and go, no, I don't believe that quack that says I've got 6 months to live. I'm going to go get some chemotherapy. I'm going to give me some chemotherapy and I'm going to live. And that's fine. And then you can go back on hospice. And the hospice agency will welcome you back. That's fine. You're not going to get blacklisted because you decided you didn't want hospice anymore. But it's challenging because if you leave hospice, then that whole team that came together gets unraveled. And they can readmit you, but then that whole process starts again. And so you don't have continuity of care then. So if hospice is the right idea for you, it's a good idea to have a chat with your hospice nurse before you decide to quit hospice. So, let me just close this door because it's getting a little cold in here. So, if you're staffing one of our clients for hospice support, and they say, you know what, I don't believe that quack, I want to go to the ER, I want to get some treatment for this lung cancer I've got, take it to the ER. That's different than any of our other clients. Any of our other clients, and in this case too, they're the boss, but you don't want to disrupt that continuity of care if you can avoid it. And so you want to contact the hospice nursing home and have them come and talk to this person. Because maybe Elizabeth is afraid of pain. And the hospice nurse can come and say, we'll be on top of your pain. We're experts at pain control. And they are, they're experts at pain control. Or maybe you're anxious about something else that the hospice nurse can talk to you about. Maybe you have a spiritual question, so they can get their clergy person to come out and talk to you about that. All right? So it's a good idea to get the hospice person involved under those circumstances. Now, that's not the same as if you got lung cancer, you're going to die, but you decide you're going to mow the lawn. And you go out and you mow the lawn and you cut off your toe with a lawnmower. That's different. You call 911 for that, because they need to go get treatment for an issue that's not related to Elizabeth's lung cancer. Okay, so usually when you're in the home with one of our clients and there's a clinical question, you're supposed to call me and say, hey, Dr. Nelson, you know, I'm seeing A, B, and C. Should we be concerned about it? Should I call 911? Can I make an appointment with the doctor tomorrow? That's one case in hospice support. The first call you make is to the hospice nurse, right? And then, remember, they're the experts and we're supporting them. They know more about hospice care than I do. But the first call you make is to the hospice nurse. Unless you cut off your toe with a lawnmower, in which case the first call you make is 911, right? Okay. So that's kind of the sequence of events that you should follow should there be a concern about your patient when you're on hospice. Remember, it's their patient and we're supporting them. This is called hospice support. We don't do hospice. We're not equal to the hospice company. They are in charge. They are the boss. They set out the rules. One of the things that we do often is provide medication assistance to our clients. And you need to know the scope of your practice and where the line is and where you don't cross that line. So each of you can provide medication assistance. That might be like, hey Elizabeth, it's time to take your Percocet. To, here Elizabeth, it's time to take your Percocet. Or Elizabeth, put your Percocet in a cup, let me help you, it's time to take your Percocet. That's all fine to do. What you can't do is squirt morphine under the tongue of an unconscious patient. I can do that as a physician. My wife can do that as a nurse. Family members can do that because they're family members, but you can't do that. And there are people that suffer even though they're unconscious. One client we had a big old brain bleed, and so she never regained consciousness. But when her pain medicine wore off, she started to moan in pain, and she was suffering, right? She was still experiencing pain. And so the family would put morphine under her tongue, and she'd relax, and her pain would go away, right? So you can't squirt morphine under the tongue of an unconscious patient, but what you can do is say to the spouse, you know, you go to bed and get some sleep. When it's time for the morphine, or if I think that your wife is suffering, I want to wake you up and you come give her that pain medicine. And that spouse is going to go, oh, thank you, great. Can you imagine the fear of going to sleep and you may miss that your wife that you've been married to for 60 years is suffering in pain and you can't do anything about it because you're asleep? Now you can, and you know, because Elizabeth's on the job and everything's going to be fine, right? One of the important things about pain control to remember is that it's much easier to control pain if you don't experience it first. So if you have a painful syndrome and your Percocet is every 4 hours, taking it every 4 hours is a good idea. Don't wait till 6 hours when you're in pain, because getting that controlled at that point is harder to do, right? You know that.
Oh my gosh.
Yeah.
After my surgery, I had the 2 blocks on my leg.
Yeah.
And they told me to ask for the morphine before it runs out. And I didn't. Oh my gosh.
Yeah. And so
my leg was being broke all over again.
if you'd gotten that morphine before the pain got bad, or before it even got there,
Yeah.
you would have never had that. And once you experience it, getting on top of it again is hard to do.
8 hours to catch up.
Great, thanks for sharing that. That's a really good example. Let's see, so we talked about scope of practice. We talked about, my philosophy. I'm an emergency doctor. So my philosophy about palliative care and hospice support is aggressive comfort care. So as bad as it is to be dying of your lung cancer, sorry, Elizabeth, it's worse to die of lung cancer with dry lips and being incontinent of stool. It's worse to die of lung cancer with dry lips, being incontinent of stool, with a pressure sore that got created. So when we're there to support it as much as possible. Making sure lips are moisturized, skin's moisturized, maybe a foot rub, making sure their peri-region's taken care of, peri-care is good, okay? So, and making sure they don't form decubitus ulcers, because as someone is dying, they become less and less active. And then they lay in bed and not move. Now, decubitus ulcers form in the following way. Like this is called my thenar eminence, right? I'm pushing it on the table right now. I pushed all the blood out of that area. If I leave it like this for 2 days, I'll have an ulcer there because the skin doesn't have any nutrition. There's no oxygen. It's not rehydrating itself. It's going to break down. Now imagine the buttocks area of a patient that's laying in the same place for 2 days. Same thing happens there. That's a pressure sore. And the way you manage that is you turn people every 2 hours, right? So if someone's laying on their left side, you'll turn them on to the right side, put some pillows on this side, so they kind of stay up on that side. And 2 hours later, you turn them back this way. That way, they don't develop pressure sores, right? So aggressive comfort care. And what that also means is not allowing the patient to experience things they don't want to experience. As you begin to die, you withdraw when you're not interested in food anymore. Maybe you're not interested in water anymore. And your kidneys are shutting down, you're not making urine. That's all normal. Family members can get really anxious about that though. They might say, Linda, I really need you to get, Elizabeth to eat something, get some nutrition. She needs some nutrition. Your job then is to help educate that family member who loves Elizabeth and say, it's perfectly normal right now that she's not being interested in any food, but I tell you what, I'm going to be all on top of her, and if she expresses any interest in food at all, and I'll ask her, I'll make sure that she gets what she needs, or water, or whatever she needs. And so you're not assaulting her by forcing her to eat or forcing her to drink or disrupting her process. She's trying to die, she's processing it, and you're like, hey, you need to drink something. And that brings them from where they were to where you are. And that's not what we're doing. So we talked about aggressive comfort care. We talked about looking for us. You know what palliative care is. You know how to communicate with somebody when it's time, to call the hospice nurse first. So, now I'm going to talk about active listening. Who knows what active listening is? Nobody? We've done it before, haven't we? Okay. So active listening is holding up a mirror to somebody when you're having a conversation so that they know that they were heard. You've all seen conversations where you're just talking with your girlfriend, your boyfriend, your husband, something like that, and you're talking and they're like, we're getting ready to say something, right? They're just waiting for you to quit having words come out of your mouth so they can say something. That's not active listening. That's the opposite of active listening, right? Active listening is maybe just saying exactly back to her what she said to me. Like Linda may say, I'm really worried I'm going to experience a lot of pain. And I may say, you're really worried about the pain, aren't you? Or you may just say exactly the same words. You're really worried about you're going to experience a lot of pain. And I've been doing this 30 years and it comes pretty naturally to me now, but when I initially started doing it, it felt fake. It felt phony. When I went to practice it on people, I was convinced that, they're going to know I'm just like playing some game with them. Nobody catches on to that, generally speaking. Because it's such a refreshing experience to have somebody hear you. And so your job is to communicate back what it is they're communicating to you. And that lets them process what they're going through. Either the dying person, the hospice patient, or their family members, because you're going to help them with this too. This is a privileged position you have. And remember that the majority of communication is nonverbal. So if I'm after listening with her, I might just do this and just match her body posture. People want to talk to people that are like them. If you put 100 people, dump them all into a room, all different races and ethnicities, stuff like that. The white people go kind of together initially, African American people go together initially. That's just because you kind of gravitate to people that are like you. That's evolution. That's evolutionary because people that are like you are from the same tribe and they're unlikely to kill you, and so we do that unconsciously. And so you want to try to match their body posture if you can. And actually, when I was practicing active listening with somebody on the very first hospice support lecture, she was doing that unconsciously to me. I'd move around, she'd move like this, and I was like, wow, that's really a good idea. The other thing is that if we're talking, and you're saying, I gotta get the oil change in my car. Well, should I active listen by saying, you need to get the oil change in your car, or should I say, you seem troubled by that, right? She didn't use the words, I'm troubled by this, but you could tell she was crying about the car. And so, use your head and think about this. We're going to break up into groups of 2 each, right? And you and I are going to practice active listening with each other here to demonstrate it, okay? And then you guys are going to go do this project. And then you have a homework assignment afterwards. I want you to find 2 people to practice active listening on in your personal life and then the next week, 5 minutes. And they won't know that you're doing something weird, because it's not weird. They're gonna feel great because you validated them, okay? And then in each of your clients, do some active listening every single shift.
You can do it on a telephone too.
You can do it on a telephone too, yeah. It's a little harder, I think, on a telephone, but you could. Before we make this demonstration, there's one last thing I want to leave with you, is that if you happen to be on shift with someone that's dying, and they die while you're on shift, well, a couple things. What do you experience when they're dying? First of all, people will lose consciousness, their breathing will become erratic, and then they'll stop breathing, right? That's normal. There might be a rattling sound called death rattles. That's normal, nothing to freak out about. But if you happen to be there at that point, recognize what an incredible privilege it is to be present for that person when they're dying. That's the only time they're going to die. And for the family members of that person, that's the only time that family member is going to die for them. Incredible position of privilege. If your shift ends at 7 p.m. and they die at 6:59, don't clock out. Stay. The family needs you still. You'll get paid for it. Don't worry about that. The family needs you still. They want you to help wash the body, to get the body ready. Maybe they need a sandwich. Maybe they need to be some talking. Maybe they need to talk to you about something. All right? So there's no rush. You will take that experience with you for the rest of your life. It's a privilege. Stay there. I'll give you an example of something I'm really proud of in this company. We had a client that died, and I heard that they died, and I knew who was on shift. And it was, I don't know, who knows Arena here? Yeah. So she was on shift with this person, and Arena is one of our caregivers. And I heard that she died, and I also heard from the office that they really appreciated Arena being there, right? And so I waited a couple of hours, so I knew she was not going to be there anymore, to call her and say, hey, I heard you did a good job, thank you, you want to talk about this, anything on your mind? And I went right to voicemail. 5 hours later, she called me as she was just leaving the home. She stayed an extra 7 hours. She made dinner for everybody, she helped with the body, she was wonderful. And we get testimonials from family members about how wonderful our caregivers are in their home and how they became like part of the family. You've read those testimonials, Mom. So, so just remember that. Let's see. So let's practice some active listening. Why don't you bring your chair up here? So we're going to demonstrate it for you. And she and I have never done this before, so I don't know how it's going to come out. And I'm going to be the listener, and you're going to be the talker. And when you guys do this with each other, it's better to think of something real for you that has emotional content. Because it's going to be more, it's going to be better than a person that's practicing active listening. Also, when you do this, when you're the talker, you don't just talk in a long speech, because you're not giving me a chance to do any active listening. This is practice for the active listening, okay? So you say a few things, then you stop. Then you see what they have to say. Then you say a few things, and you stop. And you hear what they have to say, okay? And it's okay that nothing gets said at all. That emptiness. We want to fill, when we're having a conversation with somebody and nobody's talking for a while, it's really awkward. And you want to like throw words at them. Not the time to throw words at them. You stop. You keep your mouth shut. It's also not the time to tell this dying person, not try to make them feel better. If they're like, I'm really afraid of dying, it's not going to be okay. It's not going to be okay. They're dying, right? So it's not your chance to make them feel better. It's not your chance to share any of your experiences in your life. It's not your chance to tell them about how much you love Jesus, and they should love Jesus too. It's inappropriate, okay? Absolutely inappropriate. It's their time to talk, your time to listen and demonstrate that you have listened. So can you think of something that has some actual emotional content for you? I know I put you on the spot at the last minute.
Heather, this, I can't think of anything emotional right now, but we can just go conversationalist.
Go what?
You just talk.
Talk about something that, you can make something up, Zen, if you want. You're a dying patient, now you're acting. Acting. So, you're dying of lung cancer, it's horribly painful, you have a family that you're leaving behind, you didn't prepare for that. They're young still. You're not going to see your kids graduate from high school. Okay, and remember to pause once in a while so I have a chance to talk.
Hi, Dr. Nelson. I just got diagnosed with stage 4 lung cancer, and I've got so much left I don't know how I'm gonna deal with it, you know.
There's a lot on your plate.
Definitely. I have 2 kids and my husband and my mom, and I'm only 34, and I don't know how I'm gonna deal with this. I really don't. I'm just speechless. I don't know how to do.
You don't know what to do?
No, I don't. I mean, I'm so young. I have so much to offer still. I have so much life to offer, but I'm just
All of what you could have given your family, you're not going to be able to do.
no, pretty much. I feel like I'm leaving them, like I'm going to leave them too soon. It's just too soon, and I'm so scared for my kids to see me dying and my family to be alone without their mother.
So you're worried about what your kids are going to experience as they watch you die
Yes,
in that process.
yes. I guess do you have any advice for me?
Well, I'd like to hear more of them.
You know, besides this lung cancer, you know, there's a lot of other things too, medical bills. I don't want to leave my husband financially in trouble, and then my mom is also sick, and I'm the one that used to take care of her. Who's going to take care of my mom? Who's going to take care of my kids? You know.
You have all these responsibilities.
Oh, definitely. So many responsibilities. It's just so difficult. I can't process it. I can't think about it. I feel like I'm so depressed all the time. And there's sometimes I yell at my husband because there's just, I don't know what to do. I don't know how to express my feelings so it comes out. I just yell.
Sounds really frustrating. You're yelling at your husband, but you want to express your feelings and you're not able to.
Right.
Good, okay. So she asked for advice, I didn't give it. She did a pretty good job for that. So I didn't give the advice, and I didn't feel the rush to like be charity. So that's it. It's hard to do. I think it's very hard to do. When I first started doing this, it's very difficult to do. So that's why you have homework assignment practices, okay? You're gonna practice this with each of your clients when you go in there. Once a day. This is like extra service you're giving them. They're not even paying for that. You're like counseling. It's kind of like counseling. One thing you can say that isn't active listening, but it's kind of part of the thing, if you can ask somebody if they're having difficulty expressing themselves, you can ask them, how do you feel about that? Because the concept behind this is to get at their feelings, to get something deep going on. If they start to cry, you did your job. That's good, because they need that process. Like Heather was down here, she's been my primary subject, for this. And she starts talking about stuff, and I started active listening. She just started bawling, right? Because, and it's good, because she processed that then. Your job is not to be uncomfortable with that kind of stress and that kind of pain. Your job is to facilitate that, all right? So, by a show of hands, who thought that was really easy to do? You thought it was easy?
I don't know, I just like to talk.
No, the active listening part. The talking part.
The other side.
Yeah. So I think it's hard. I think it's hard to do well. And I'm pretty good at it now, but I wasn't for a long time. That's why you have to practice this. Practice on our clients. Practice on 2 people in your personal life over the next week. Homework assignment for everybody. Anything anybody wants to ask or make comments about hospice support? Yes, Linda?
I just wanted to say with active listening, a long time ago I got really good at it.
Yeah.
And then I quit doing it for a while.
Yeah.
And to get back into it, it's kind of hard to get back into it.
Yeah, it is hard. It's a skill set.
Yeah.
It's a skill set. And it, I told you about the Kubler-Ross stages and stuff, so just read this. These first 2 pages take home with you, learning objectives and the Kubler-Ross stuff. We're already going to do the test now, but I'm always available as a support if you guys ask a question, but I can clinical stuff to go over. And also, if you're in home and you need help with something, you can always give me a call. And this is hard. This is, if you're staffing dying people, you're going to get close to family, you're going to get close to the person that's dying. It's going to be hard. And if you have your own issues about dying, bring those up for me. So remember that.